Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Hello, everyone. We have some exciting news for the listeners of this podcast. It's with great pleasure that I'd like to introduce my colleague, Dr. Kathryn Eubank, who's a professor of medicine at the University of California, San Francisco, like myself, and also medical director of our Geriatrics consult service and our MACE, or Acute Care for Elders unit, at the San Francisco VA Medical Center. Dr. Eubank will be hosting some of the upcoming episodes, including this one, and I hope you can give her a warm welcome with your ears and look forward to an engaging conversation with Dr. Eubank and her guest.
Hi, my name is Dr. Kathryn Eubank. As Dr. Chodos mentioned, I am a geriatrician and a professor of medicine here at UC San Francisco. I'm excited to be joining the Dementia Care on Air podcast, and I look forward to hosting over the next several sessions. Joining me today is Sarah Hooper from UC Law, who I will ask to introduce herself.
Hi, Kathryn. Thanks for having me. We've had the pleasure of working together for a number of years. I'm a professor of practice at UC College of the Law in San Francisco. I direct our Health Law and Policy program, which is affiliated with UCSF. And I also direct a project of DCA called the Statewide Medical Legal Partnership Network.
I'm so excited to be here with Sarah today. As she said, we have worked together over the years on both some clinical projects as well as education, and I've learned so much from her. So I'm really looking forward to hearing about her thoughts on today's topic, which is social risks and benefits of dementia screening. So just to get started, I think maybe we should take some time to define what social risks are. Sarah, do you have any thoughts about how you define social risks?
Yeah, we were thinking of this as a set of concerns or implications associated with cognitive screening that are about social determinants of health. And so concerns that patients or caregivers might have about cognitive screening and what it would mean for their life socially. And these might come up organically for clinicians or patients might ask about them directly, or you might sense some hesitation in bringing up cognitive screening. And so we thought it would be helpful to talk about them so that clinicians could feel prepared when those issues come up.
Really like that definition. I think about it too as just opposed to, we're often as clinicians used to working within the medical realm, so medical risks and benefits that we're thinking about when we're doing any intervention with the patient. And this really moves it into another area, things that bring up new needs or new social losses that the patient or caregivers may be thinking about. And you're right, that may make them not want to be screened. And so I think of these as different risks, as you've said, and maybe we can just start to list some of those risks and we can discuss it from there. What's one of the risks that you often come across, Sarah, as you're dealing with patients?
In dementia in particular, or in particular with older adults at risk of cognitive impairment, the kind of I'll name four key issues that may come up for clinicians. One is what impact a dementia diagnosis or even just a positive cognitive screen would have for their employment and income, their economic stability. Another would be long-term care access. What does this mean? What kind of needs will I have in the future? And does this influence my ability to obtain them? Will I be able to make my own decisions about my life? And will people try to take over if they think that I'm no longer able to make decisions on my own? And those decisions can be about a range of things, including medical decisions, financial decisions, and other issues. And then lastly, about driving. As people become more impaired, we start to worry about their ability to drive. And patients are worried about their ability to drive as well, right?
Definitely. Definitely something that I hear about from my patients. So just starting back with employment, I think one of the interesting facts that came out on the webinar on this same topic earlier this month was that the population over 65 that will be working will be increasing over the next 10 years by 95%, which was kind of a shocking number to me. And really both out of necessity and with healthier aging people that want to continue to work. And so I can see that as we start to screen that some people may have concerns about how this is going to affect their employment. What are those specific things that can be affected with employment?
Yeah. So, of course, if we are starting to worry about our cognitive ability in any domain, we'll be worried about it in the domain of employment and our ability to maintain our employment. And patients may be concerned that if they engage in cognitive screening with a provider, that their employer will find out and that people will start to have doubts about their ability to work and they could get fired or otherwise lose rights at work. And then caregivers as well may worry about how they will be treated by an employer who finds out that they are going to be undertaking a lot more caregiving responsibility or care supporting responsibility, either now or in the future. And so it's important for clinicians to know that these are worries that people have and may associate with cognitive screening. And what's important to remember is that people have rights in the workplace. Both older patients with dementia or at risk for dementia have rights in the workplace, as do caregivers who support them. And so the main takeaway for clinicians is to link people to resources to help them advocate for their rights as early as possible. There is lovely work by my colleagues, Sharon Turman and Katie Wichett at an organization called Law. They have a wonderful Dementia Care on Air podcast about this topic. They talk to Anna Chodos about this and have free resources for people who are concerned about their workplace rights. So a very easy thing to do in talking to a patient or a caregiver who's worried about the impact a positive cognitive screen or a dementia diagnosis may have on their employment and income would be to say, you have rights in the workplace and I can connect you to resources to address those.
I want to maybe give you a case and what the response would be. I can see a patient and they're continuing to work and they were screened at a doctor's urging for us to screen the person, and they were diagnosed with mild cognitive impairment, actually not dementia yet. And unfortunately, the word got out between family members and being close to other work people. It became known at work that this person was suffering from some mild cognitive impairment. And they were worried about how that was going to impact both their job in of itself, as well as other opportunities. Like there might be opportunities coming for advancement or projects that they wanted to work on that they were afraid that people would no longer consider them for, because the word cognition was now being thrown around, even though they were very confident that their cognitive impairment had not affected their work. And so what are those rights that these patients have in the workplace?
Yeah, so it's important to know that employees cannot be treated worse by their employers due to age or disability. There are state and federal laws that prohibit discrimination on those bases. And so it's important just to understand that patients and caregivers have rights in the workplace, and that they may be afraid. People are often afraid to assert those rights in the workplace, but that's why legal help can be really critical in understanding what those rights are and approaching employers in the right way. It's also important to know that for people with disabilities, they can ask for a reasonable accommodation from their employer, right? So asking an employer to engage in a conversation about what accommodations would be appropriate for a particular person given their abilities at a given time and the demands of the workplace. And again, that's where having legal help from a nonprofit organization like Law in particular could be really helpful to support that conversation.
So it sounds like us as providers, if this comes up with patients, our responsibility would just to let them know what those rights are, possibly. Like, you do have the right not to be discriminated against at work based on this diagnosis. Sorry that the diagnosis came out, but you do have this right. And if there are ways that we can accommodate this at work and work with your employer to do that, then we have some legal resources here that we can send you to. Is that reasonable?
That would be exceedingly helpful to patients and caregivers, and validating to them that this is an important issue, that it affects their health, and that it's important to you, would, I think, really go a huge way in making them feel supported and really strengthen your relationship with them. So that would be wonderful if you could do that. I'll also say, as a preventive measure, if we can help patients protect that information in the workplace, right, that would be another point of education. So educating, often clinicians are asked to certify disability or to write a letter to an employer about a serious illness that a patient may have or disability that a patient may have. There are tools that our colleagues at Law have provided about how to do that in order to protect your patient and the caregiver, so that more information, so that we don't give more information than is necessary about the nature of the underlying illness. So for instance, it's not actually necessary to say that someone has mild cognitive impairment in order for a clinician to say that someone is in need of an accommodation or needs time off of work or a whole host of other things. So Law has some sample letters for clinicians on their website, which I think are really awesome, and I highly recommend them. And yeah, I think helping to prevent that on the front end would be extremely useful to both patients and caregivers.
So you mentioned the Law website. Can we just give that whole address here real quickly? Was it lawca.org? Is that correct? Or
yeah, so Law stands for Legal Aid at Work. It's a California statewide resource that is free, and the web address is legalaidatwork.org.
Okay.
And there's also a work and family helpline that is 1-800-880-8047.
Thank you for that information. It's always great when we can send patients and their caregivers to a site for more information in areas that we really, truly have no expertise in. I wonder if we could move on to that second risk we were talking about, which was, you brought up the risk of losing long-term care access. Can you tell me more about that?
Yeah, so I think many listeners may be aware that long-term care supports and services are necessary for people with dementia, and there's a whole suite of them ranging from community-based services to institutional settings. And the main takeaway about those is that they're very expensive and they are largely not paid for by Medicare. And so people end up largely having to pay for them out of pocket until they may spend down to Medicaid eligibility. And Medicaid is actually the single biggest payer of long-term care supports and services in the country. There are also private long-term care insurance policies. And the most important thing to know about private long-term care insurance is that it is not included in the Affordable Care Act, in that it there are no protections for pre-existing conditions. So since the Affordable Care Act was passed, we've all become accustomed to this idea that we cannot lose coverage or experience coverage changes on the basis of pre-existing conditions. That is not true of the private long-term care insurance market. They can and do absolutely deny people coverage on the basis of an underlying condition, and the ways in which long-term care insurance companies have denied these coverage or claims has been on very loose information in a patient's record. So it doesn't even have to be a full a dementia diagnosis. It can be any notation. There's documentation and some research our colleague Jelaine Arias has done that a patient just mentioned some concerns about memory loss to a provider who wrote that in the chart without any further screening or assessment. And that alone was a basis to deny long-term care insurance coverage. So cognitive screening in itself doesn't cause loss of insurance, but it is an important moment to talk to patients and caregivers about the fact that they are going to need to have a plan to pay for long-term care supports and services, to educate them about what those are, and to connect them to resources that can support them in doing that.
Would you have that conversation with them prior to screening?
There's no wrong time to have that conversation. And it can sometimes be helpful to revisit it periodically, particularly as people's needs change. So often long-term care supports early on may manifest as a need for in-home supportive services or someone to help with IADLs, right? Cooking, shopping, cleaning. But maybe someone is independent of certain IADLs, but not all of them. And just needs a little bit of help, right? That would be sort of like early memory loss, early cognitive impairment. And as someone progresses, they may need something that looks more like assisted living. They then may need more robust forms of care. And so we're trying to keep people in the community as long as we possibly can. For some people, that might not be an option. But for a lot of people, the reason it's not an option is because it wasn't part of standard retirement planning for them, right? Like for a long time, retirement planning conversations, and to this day, still don't include the cost of long-term care. And so people aren't adequately accounting for that. People don't understand the Medicaid program. It is a very complex program, unfortunately. And many people think that it is just the program for very poor people. But it is one that many of us will rely on, even those of us who think we are solidly middle class, because of the high cost of long-term care. So ideally, we would be having these conversations as part of retirement planning much earlier on. They're not necessarily happening that way. So anytime that a clinician is willing to start a conversation about that would be a good time.
You may not know this, but have you heard if there will be any change to how that long-term care insurance will be done? Like, is there any discussion legally about not being able to exclude these pre-existing conditions? Or is that just not part of the debate yet?
There have been discussions about policy discussions about different coverage models for long-term care for a very long time. And the most, I think, robust of those conversations happened around the Class Act, which was originally part of the Affordable Care Act, but did not make it very far. And so I'll defer to my colleague Jelaine Arias, who was with me on the social risks webinar and is doing some research on this topic. But right now, I think the big move in a lot of states is to simply expand Medicaid eligibility and make it easier for people to navigate Medicaid coverage for long-term care supports and services. in large part, a lot of the things that were meant to target Medicaid long-term care supports and services to the people who most needed them operated to actually exclude them because they're so difficult to navigate. And so there's been a really important push by our colleagues at Justice and Aging and other policy organizations to expand eligibility and make it less difficult to access services that we know people need. But the private long-term care insurance market, I'm not seeing much that is making me feel confident about that market.
Yeah, I know it's a debate with us in geriatrics quite a bit, whether it's worth patients participating in that market right now because of the way it is so restrictive that it often doesn't help in the long run. But I think it's worth having the discussion with patients, at least that they'll probably end up in a situation of spending down. That's what we see for most of our patients. And they will be participating in these other resources that we may not even think about for them right now. So I think that's a good take home point.
Yeah. And legal aid. So your legal provider through your area agency on aging or other legal aid organizations work on Medicaid benefits all the time. And so if there are issues with someone's IHSS, if someone has been denied Medicaid coverage, Medi-Cal coverage in California, legal aid provides free services and can be very helpful. And area agency on aging providers can help people at a higher income level than a lot of legal services organizations. They're focused on older adults and people with disabilities, and Medicaid benefits is one of the things that we can help with.
Thank you. Thank you for that information. I think we'll move on to another fear, which I hear probably the most frequently from patients. I would almost say it's a toss-up between I'm not going to be able to drive anymore, oh no, and this fear of loss of autonomy, that they almost stop existing. We see that a little bit with ageism as it is, that even without this diagnosis, that people can talk over top of patients or not include them in certain conversations or activities. And I think once they've been diagnosed with cognitive impairment, that fears that really does go up. And so the fear of screening is people are going to exclude me. I'm not seen as worth this time and discussion anymore.
Yeah, and it's really sad, right? None of us wants us, all of us want to feel included in decisions about our own lives. And many of us want help. It's not to the exclusion of other people stepping in to help us, but we don't want to feel that people are stepping in prematurely. And some of this, I think, is definitely tied to ageism and ableism, as you rightly point out. Other factors like race and gender can compound the ways in which people are treated as no longer mattering. And I think also misconceptions in the public and in the professions as well about what a diagnosis of dementia means, or even a positive screen or any screen indicating some cognitive impairment. There's a perception often that this means that the person can no longer legally make decisions. And it's important to know that in California, we have very strong protections. And we have something called the California Due Process and Incompetence Determinations Act, which says that even if someone has a diagnosis of a mental illness or a disability, that does not mean that they automatically lose the right to make their own decisions. And in fact, we try very hard to maintain people's ability to make decisions about their own lives, in part because it's the right thing to do, in part because it's bound up with civil rights, right? Constitutional rights, to make healthcare and other decisions that affect our own lives. So legally, it's really important to remember that a diagnosis and any screen doesn't tell you if someone lacks legal capacity. It doesn't tell you if they lack functional capacity, right? So clinically, we know people experience different rates of progression, and it has really variable impacts on their their ability to function in different areas. And so it's both a matter of fact and a matter of law that people can and should still be able to make their own decisions about their own lives. And so, for all of us who are working with these populations, we need to remember that, and we need to act accordingly and treat patients as the way that we would want to be treated in the same situation.
And even though I feel like this is often perceived as a big risk of screening, I actually look at it as a benefit of screening and catching the diagnosis early so that patients can still determine their futures as far as things like appointing people in case something happens in the future where they can't make their own decisions, that I still have somebody that I can trust. I think in medicine, we're most familiar with this around a healthcare agent or a medical decision maker. And I think we're less familiar with that around financial decision making. And so can you talk about helping patients make these decisions also for their financial futures?
Yeah, it's a great point, and I couldn't agree more. It's something that may feel really scary to patients, but is a real opportunity and a benefit of early screening that we can, if we talk about it in the right way, we can take it from being something that feels disempowering to something that feels empowering, which is we're going to get some information that's going to help us figure out how we can make decisions together about your future and give you some options to really plan ahead. So I think that reframing and that kind of positive look on it is really important. And the financial piece, so you're right. So, if someone receives a positive screen result, that would be a really good time to start talking about planning for the future and encouraging patients to do that and framing it as something that would be their choice, right? And legally, they're the one that has to do the planning. It's not something a caregiver can do for them. It will not be a legally valid plan if the caregiver does it for them. And so we have to put the patient in the captain seat because legally they're the one that has to be there. They can appoint a healthcare agent. And it's also important, as you say, that they think about financial decision making for the future, because healthcare agents don't have the ability to call PG&E to get the power turned back on when patient forgets to pay the bill, or to work with an attorney to fight an eviction if patient is getting evicted, or to make a whole host of financial decisions that will be necessary to provide long-term care supports and services to someone over the course of their life. So it's really important that even if we think someone isn't able, and especially if we think someone isn't able to manage their finances independently, that we have a conversation with them to see if they can name someone who could. Right. And that's a key distinction. Someone doesn't have to have the ability to do the task itself, to still have the legal ability to say who they would want to do it for them. Right. So that's really critical. And we often think of advanced care planning as being about death, but especially for people at risk of incapacity, they could live with impaired capacity for many, many years and need a lot of support and people around them who are trustworthy to support them in making a range of decisions. So it's important to get that decision-making support network in place as soon as possible.
And is that something that I can do in my office?
You absolutely could have that conversation with patients and should. There are tools like prepareforyourcare.org that assist people in making healthcare decisions and appointing agents. There are tools that will be available soon to help people understand a range of financial and legal planning decisions that need to be made in dementia. And simply raising the issue and encouraging patients to name those people and then referring them to places like lawhelpcalifornia.org for free or low cost help would be a huge step in encouraging planning with patients.
And so I'll remind our listeners that we do have a module on advanced care planning on the Dementia Care Aware website. It will be posting soon, and that you have gone through in much more detail than we have time for here, the different type of financial decision makers that can really help our patients have the type of future that they want. So I'll just refer them over to that. And that should be posted, by the way, in the next week. So definitely look at the Dementia Care Aware website. The last risk that we talked about was driving. We have a few minutes left here, and I wondered if you could tell me about that driving risk. It's something we hear a lot from patients. We're drivers in the United States, and so they don't want to give that up.
Yes, so I should say, driving in the US is associated with independence. And so losing your ability to drive is a dignitary loss for a lot of people and a practical loss for a lot of people. The ability to drive may mean the difference between being able to work and not work, being able to get to your office for a medical appointment and not being able to get there, being able to go to church and having, social engagement in the community. We know that social isolation is a huge risk factor for older adults and poor health. So it is a real significant loss in people's lives. Even while we think and know that there may come a time for people when it is truly unsafe for them to drive, and we may agree that it is not right for them to continue driving. I think it's helpful for clinicians, even if you agree that someone should no longer be driving, to just validate for the patient or the caregiver that this is a loss and it's really hard. And just being there to support them emotionally, I think, is really important. You do have a specific role with regard to dementia and driving in California, which is that we have a law requiring that clinicians report when a patient is impaired to the point that you worry about their driving. A positive cognitive screen does not trigger a report necessarily. It's more the functional aspect of it. If the person is impaired enough that you think their driving that they're not safe to drive, then there's a reporting requirement in California. It's a report to the Department of Public Health. The Department of Public Health will then write a letter to the patient and ask them to come back and ask you for a medical evaluation. If the patient doesn't give you the medical evaluation or doesn't consent to your giving that information out, there is a ticking clock. And so they will have their driving privileges suspended if they don't return that form. The form is a few pages, and depending on how you respond, what information you give, and how severe you think the person's impairment is, the DMV may decide either to have the patient retest, essentially take another test and see if they can still drive, or they may just immediately suspend their privileges, depending on what you say in the form. And that can be a hard moment for people. Again, I think that focusing on supporting the kind of emotional impact of that to patients and caregivers is going to be really important. And then supporting the practical component of it. So actually helping to address the underlying concern about transportation would be a really helpful thing for clinicians to do. Or if you have someone on your team, like a social worker, patient navigator, something like that, who can connect them to resources, that would be valuable. The Medi-Cal program pays for transportation for both medical and non-medical visits. There are other programs available through your local area agency on aging. If you don't have your area agency on aging on speed dial, I recommend that you get it. There's one in every area. They have free and low-cost services to older adults and people with disabilities. And And finally, it could be something as simple as, have you ever used Uber or Lyft, right? This may be a group that hasn't started using these apps yet, and maybe they can afford to use these apps and they just haven't learned how to use them. And that brief intervention could be really life-changing for their autonomy and sense of independence. So those are just a few things about driving. It's a really deep area that we could probably have a whole podcast on, but I hope those are a few tips that are helpful.
Very, very helpful. So I'm going to wrap up here and kind of touch upon some of the take-homes, at least for me, as you were talking. I think one really important thing is that patients do have fears around being screened for cognition, and even more so about the fact that they may lose their cognition in the future. And so having the healthcare team really listen and acknowledge those patient fears, but then I would take it a step further from that and saying, another thing that you brought up was turning that into a positive. So really thinking of how we can mitigate these risks and these fears that patients or their caregivers are bringing up. And so some ways to mitigate that is to really encourage medical, financial, legal, advanced care planning, tie patients and their caregivers into information and resources that can help them navigate things like employment or long-term care access and even driving, and making sure that we have that information and those resources readily available in our offices so that the patients can connect very quickly to those. And I think another important point that you brought up was just being very cautious who we share information with and how much information needs to be shared when we're asked for information, that we don't need to share very much. And being specific about that with patients too, that they don't need to share this information with people so that they don't get trapped in a situation where they can be discriminated against. Anything to add to those, Sarah?
I think that was a beautiful summary. And I think that this would be, from a patient perspective and a caregiver's perspective, having clinicians do this would mean the world, to feel like you have an ally who understands that there is no disconnect between medical and social from the perspective of the patient, that all of these things are blending together. And often patients just don't know where to go or where to start. So any amount of linkage that you can provide will be incredibly valuable and critical to patients. So appreciate any steps that you can toward that end.
Thank you so much, Sarah, for being with us today and for sharing your wisdom in these areas. And with that, I think we will wrap up for today, and we will see you on the next podcast. Thank you.
Thanks, Kathryn.
Thank you for listening, and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you know you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia Careware team. If you want to learn more, please visit our website, dementiacareware.org.